So for this case, we have a 56-year-old male presents with altered level of responsiveness. He's found to be febrile and has a blood pressure of 104/40. So like you do with any sort of altered patient, you want to hook them up to the monitor and see what's going on. And this is the rhythm strip. As you can see, we have what appears to be a narrow complex tachycardia. So narrow complex because each individual QRS complex is narrow, and a tachycardia because just by eyeballing the rate, you can clearly see that it is above 100. If we look at each of these individual R to R intervals, we can see that in some cases the heart rate basically gets into the 160s, 170s range. But there are also periods where it's a little bit slower. So if we look at like these two complexes right here, it's kind of more in the low 100s. Now, because of this, we can identify that the rhythm is irregular, and when you're presented with an irregular rhythm, there's really only two things or three things that can cause that. You either have a fib, a flutter, and sinus tach can also produce some irregular rhythms. So when it comes to determining what of these three things this rhythm is, it's really all about the degree of irregularity and then what the atria are doing. So the degree of regularity, as you can see, is pretty significant. There are complexes that get close to like 200 times a minute, and then there are complexes that chill out a little bit and are more in the low 100s. We also notice that there's no real organized atrial activity. There's no real defined P waves preceding each QRS complex. You see some blips in between each QRS that could look like it could be a P wave, but to be honest, it's just there's nothing uniform there, and so we can not call it sinus. Because of this distinction or the absence of uniform P waves, this means that a flutter is out, as is sinus tachycardia. You can't do it. No sinus tachycardia here. So this means that what we're looking at is atrial fibrillation with a rapid ventricular response. Now, having identified the rhythm, we want to figure out what the next step is and how to manage this. So, based off of this case, we identified that the patient is altered, which is a sign of inappropriate end organ perfusion. And then, if we look at this blood pressure, the systolic seems to be all right, but the diastolic is quite low. And so, a lot of times when you are confronted with a situation and you have a low diastolic pressure, you should be concerned about some distributive shock process. And so the first, second, and third cause of distributed shock, especially with somebody in a fever or a febrile state, is going to be sepsis. And correct spelling. So sepsis. And so the treatment is quite simple. IV fluids in accordance with the sepsis protocol, usually 20 milliliters per kilogram, titrating to blood pressure. And just know that this is probably as a result of an increased catecholamine surge. And the primary cause of his altered level of responsiveness and low diastolic pressure is, in fact, a sepsis illness, not a primary arrhythmogenic state.